Our first speaker is no stranger to our university. She actually was a part of our very first Skin of Color Symposium in 2018, and we loved her so much. We wanted her back, and we are so happy to have Dr. Heather Woolery-Lloyd. And she is an internationally recognized expert in skin of color. And she's lectured far and wide across the nation and internationally on the cosmetic concerns of skin of color. She completed her undergraduate degree at Georgetown University and earned her medical degree at the University of Miami School of Medicine, and also stayed there for her dermatology training. She participates extensively in clinical research, focusing on skin of color dermatology, and she's very active within the American Academy of Dermatology, the Skin of Color Society, and also serves as the director of the Skin of Color Division for the University of Miami Department of Dermatology and Cutaneous Surgery. Dr. Heather Woolery-Lloyd is going to talk to us today about a very interesting subject that I think all of us need to be aware of. It's something that, especially in dermatology, we deal with on a regular basis, and that is African American hair and scalp disorders. So thank you, Dr. Woolery-Lloyd.
Thank you so much. I'm happy to be here. So I'm going to share my screen and get started. This is always a very fun talk for me because there's a lot to be learned. So first of all, I want to thank you for inviting me. I remember the very first meeting several years ago, and I loved visiting Oklahoma. I had never been to Oklahoma before. And even though it's virtual today, I'm really happy to be here. So this talk is on African American hair and scalp disorders. And this is a big part of my practice. I see a lot of hair and scalp disorders. Before we jump in, I want to go over these are my relevant disclosures for this talk. None of these are specifically relevant to hair disorders, but these are my disclosures. And the reason why I think that this lecture is important is for all healthcare providers and those in dermatology, really understanding African American scalp and hair disorders is important, and specifically understanding how hair care practices influence these disorders. So we're going to focus not only on the disease processes, but also on how hairstyles influence these disorders. So our objectives are to review CCCA, central centrifugal cicatricial alopecia, which is the most common type of hair loss I see in my practice, scarring alopecia. We're going to talk about traction alopecia. We'll talk about frontal fibrosing alopecia, which is on the rise, unfortunately, and also discuss the problems that I see in my practice with the use of glue, which is a common way to add extensions to the hair. So, as I mentioned, in order to really understand African American scalp and hair disorders, it's really important to understand the hair care practices that contribute to underlying disease. So the things that we'll go over are unprocessed hairstyles like afros, locks, twists, and braiding, extensions, hot combing, which was a hot topic when I was a resident over 20 years ago, but actually is less important, I think, today, chemical relaxers, and also keratin treatments. So the only hairstyle that's not associated with any type of hair loss is the afro. And this is a beautiful natural hairstyle where basically the hair is cut short or relatively short, although you can have a long afro, but there's no tension on the hair, there's no chemicals in the hair, and pomades or oils are usually applied to improve manageability, but it's really not associated with any particular type of alopecia. And my talk would actually end here, probably, or most of our problems would end if our patients only had afros. But of course, everybody loves to express themselves through their hair. So there are many beautiful hairstyles that we'll talk about today. So the hairstyles that are associated with hair loss are extensions, cornrows, locks, traction, so really tight hairstyles, chemical relaxers possibly, although the data on that is not as strong, keratin treatments, which also are similar to the Brazilian treatment that people do to their hair and hot combing. So let's jump into it. So extensions are when the hair is either braided onto existing hair or glued onto existing hair. And it's a common cause of traction alopecia due to excessive tension on the hair. So you see a nice teenager here with her braided in extensions, and these are very long. The longer the extensions are, the heavier they are. In younger patients, we don't tend to see too much of an issue unless they're done very tightly. But as people get older, if they continuously wear very long extensions, we can see traction alopecia. Now, sewn-in extensions, if your patient says they're getting a sew-in, it means that the extensions are actually braided into the hair. And sometimes patients will refer to this as a protective hairstyle. So you can see this woman here, she has short hair, her hair is cornrowed down, and then the hair is braided onto those cornrows. So it's a very common practice. It's considered protective. It actually usually doesn't cause many issues, but if those cornrows are very tight, again, you can see traction, especially on the frontal hairline. Now, this is one of the biggest culprits, and this is glued-in extensions. So this is when a glue is applied sometimes to the scalp, or sometimes it's applied to a cap that's on top of the scalp. And the hair glue, the most common hair glue that used to be used included these ingredients: natural rubber, latex, water, ammonium hydroxide, and paraphenylene diamine. And if any of you study contact dermatitis, 3 of those are probably one of the biggest problems for patients with contact dermatitis. So imagine applying rubber, latex, and hair dye to your scalp and then leaving it on for weeks and, for in some cases, months. So if anyone has any type of sensitivity, any types of allergic reaction to or contact dermatitis to these ingredients, you can imagine the type of inflammation that can occur. So in my practice, the one hairstyle that I tell all of my patients to avoid is glued-in extensions. And this is one of my patients. So remember, I just mentioned that the hair can be glued to the scalp or it can be glued to the cap. So she had a cap, a stocking cap. Her hair was braided down. They put a stocking cap on her scalp, and then they glued the cap to her frontal hairline. And then the hair was glued to the scalp. So you can see she had a tremendous, robust inflammatory reaction with purulent exudate. And she wasn't here for this visit, by the way. She was here for something else, but I wanted to take a look at her scalp. And this is what I saw when I pulled back the hair. And you can imagine having months and months and months or weeks and weeks of this type of inflammation could lead to alopecia, and usually permanent scarring alopecia, which I see relatively frequently. The good news is that this problem is actually going down. It's becoming less frequent because people are avoiding glue more recently. This is a patient who had the cap applied, and you can see right where the glue was applied, she had this very robust inflammatory reaction that basically resulted in pretty deep dermal scarring. She came in when it was actually still crusted. It healed to this point. Then I did some intralesional steroids. I was probably treating the underlying CCCA that she had that caused her to want to use the glued-on cap. But so we have some regrowth and her scar looks a little bit better, but obviously this is a permanent problem. That's not going to resolve. So the other problem with hair glue is that it's associated with anaphylaxis. And there are multiple case reports in the literature of anaphylaxis to hair glue. And you can imagine if you're working in the ER and someone comes in with anaphylaxis, the last thing you're going to think is that it's the glue applied to the person's scalp. But this is actually well reported in the literature. And this woman was a London woman who actually died after a severe allergic reaction to hair glue. So hair glue is a big problem in my practice, and I always tell all of my patients to avoid glue. So the reasons why we do this is because it can cause irreversible alopecia, but also anaphylaxis. That's a big problem. Now, the old-fashioned glue that I mentioned, the one that I said that has black hair dye, rubber, and latex, what was used most frequently up until around a few years ago. And then a new glue came onto the market, and this glue contains lots of other contact allergens. So it contains methacrylates, these methacrylates and acrylates, which we know also are on the top of our lists of things that can cause contact dermatitis. And all of us remember the woman who used Gorilla Glue to do her hair. She was actually trying to replace this product you see up here on the top right that got to be glued spray-on product to apply the cap to her scalp, or to kind of get her hair the way she wanted it. So the acrylates also can cause contact dermatitis. And in general, I tell my patients to stay away from glue. Now, locks are a beautiful hairstyle, and it's a natural hairstyle where the hair is not combed and forms knots spontaneously. So small locks are achieved by twisting the hair. And when we see very long locks, they're associated with traction alopecia. So the most common presentation I'll see is a patient who has very long locks, maybe down to the mid chest area, and has been wearing those locks for 20 or 30 years. And those locks can be very, very heavy. So you'll see traction not only on the hairline, but sometimes you'll see types of traction on the crown of the scalp. And that's because the hair is very, very long and constantly pulling. So the area where the lock is placed gets smaller and smaller. You can see a really thick lock at the bottom, but at the base, it's very narrow because the hair is thinning. Cornrows are a type of braiding where the hair is braided adjacent to the scalp. This is Alicia Keys and this beautiful, beautiful hairstyle that she's wearing. It's been practiced for centuries in Africa and is common today in African-American children and adults. And it's a common cause of traction alopecia if the hair is braided too tightly. So again, I do see traction from cornrowing. A lot of patients, because these hairstyles are so beautiful and so elaborate, the hairstylist tries to do it as tightly as possible because it lasts longer. Obviously, if this was done very loosely as her hair grows out or as she sleeps, it starts to get very messy. So the hairstylist thinks they're doing the patient a favor or their client a favor by tying the braids, by braiding very tightly so that this beautiful hairstyle that takes hours and hours and hours to achieve, like something like this could take 4 hours or more. And when you see your African-American children with these beautiful elaborate hairstyles, those can take up to 8 hours. So if you have a little 6-year-old who's sitting patiently, even sleeping sometimes, getting their hair done, the hairstylist thinks they're doing the patient a favor by making it as tight as possible because then it lasts longer. The downside to that is that you can get too much tension on the hair follicle and you see traction alopecia. And sometimes in my patients, I'll see little pustules on the frontal hairline where you really see that hair being pulled too tightly. You see tenting where you see the hair actually be pulling the scalp up because it's pulled too tightly. And there are even case reports of the literature of subgaleal hematomas because the galeal veins are the vasculature is very superficial. And if it's pulled too tightly, you can even get a hematoma. Those are just a handful of those reported in the literature. So for my patients who love cornrowing, I just emphasize that we need to not do it too tightly. Even though the stylist is trying to do their client a favor, it really isn't great for the hair when it's done too tightly. One of my favorite quotes is from Dr. Kumalo in South Africa, who says, avoid all hairstyles that induce pain. So a lot of patients after they get their hair cornrowed will be like, oh, I had to take Tylenol that night or Motrin that night. If you have to take a painkiller, it's a little too tight. Now, move on to multi-tufted braiding. Now, this is just multiple ponytails, very, very common hairstyle in young children. And it is a common cause of traction alopecia. When the ponytails are too tight, this usually see the traction on the frontal hairline. And that is something that we see in kids more than adults. The only time we see it in adults is when women wear high ponytails, so a very tight high ponytail can cause traction also. Chemical relaxers used to be utilized by the majority of African-American women, but now with the natural hair movement, they are less frequently utilized. I don't have updated statistics on that, but probably less than 50%. But they basically, a chemical relaxer uses various chemicals to break the disulfide bonds and to chemically straighten the hair. So you can use sodium hydroxide or guanidine hydroxide, and basically they break the bonds. The relaxer is combed into the roots of the scalp. So this is a chemically straightened hair. It's permanently straight. It will not revert back to its naturally curly state. So this is permanently straight hair, and the relaxer is only applied to the root. It's combed through, and then it's repeated at 6 to 12-week intervals only to the new growth. So there are two types of chemical relaxers. There is sodium hydroxide, which is the most effective. It's sometimes called a lye relaxer because it is sodium hydroxide. And then there is guanidine hydroxide, which is the popular no-lye relaxer. So some people will say, oh, I'm doing a no-lye relaxer, or I'm doing a kitty perm. When you hear the person say, I did a kitty perm, that means they use guanidine hydroxide. And guanidine hydroxide theoretically is a little bit less irritating to the scalp. So it can be left on the scalp longer, and it's usually sold in the at-home kit. So people who do the relaxers at home that they buy at the local store, their beauty supply store or drugstore, is something that they do at home. So it's less irritating, but it can be a little bit more drying to the hair, probably because people leave it on longer. Lye relaxers are very irritating to the scalp. So they start to burn the scalp pretty quickly and are washed out relatively quickly. So the hairstylist has to work quickly to straighten the hair. With guanidine hydroxide, there's a little more wiggle room. The downside of that is it can be a little more drying to the hair. And then there's thioglycolates. These are the chemicals that were used in curly perms that were popular in the 80s when everyone had curly hair. These are typically very drying and not typically used in people of African descent because they're generally not compatible. They would cause breakage. So what happens when women chemically straighten their hair? Well, the cysteine decreases in the hair shaft. So cysteine, as we all know, is a component of the disulfide bonds, and they're responsible, the cysteine content in the hair is it's not solely responsible, but plays a big role in hair strength. So when you look at relaxed hair, so people who have chemically straightened hair, the proximal hair closest to the scalp has a 50% reduction in cysteine compared to untreated natural hair. So if you take natural hair that's never been exposed to relaxers, the cysteine levels are normal. If you chemically straighten the hair and you just sample the root of the hair, there's a 50% reduction in cysteine. And then if you sample the distal hair, and that hair theoretically has been exposed to the chemical multiple times, you see a 75% reduction in cysteine compared to untreated natural hair. And this level of cysteine reduction is similar to those seen in trichothiodystrophy. So the take home is in natural hair, the afro that I started my talk with, there's no change in cysteine between the proximal hair and the distal hair. The hair is healthy and much stronger. Whereas in chemically relaxed hair, the cysteine levels decrease, and it correlates with fragile, damaged hair. So when women do chemical relaxers, they can cause the relaxer or chemical can cause a superficial self-limited burn to the scalp if left on the scalp too long. But they can also cause significant breakage. And some people call this a chemical alopecia. Some people call this acquired trichorexis nodosa. So this is breakage from a chemical relaxer. This is one of my patients who saw me. This slide is probably 10 years old. So she saw me over 10 years ago. She came in and she said she got her hair straightened. You see her straight hair on the outside, and on the inside or the posterior scalp, you can see that all of her hair broke off. She said they did her hair, when they washed it, it all just fell into the sink. And that's because probably, as I mentioned, that problem with the cysteine. So this can happen and people can have a lot of breakage. Now, the good news for her is that this didn't really affect her scalp. It affected her hair. So I saw her many years later. You can see she's gray here, and all of her hair grew back, but she stopped doing chemical relaxers, and you can see this is her natural hair. Now, the keratin treatment is sometimes called the Brazilian blowout. And this is a treatment that causes lots of systemic side effects. So the original Brazilian blowout was developed in Brazil, and hairdressers used to do this treatment in front of an open window with a fan blowing because there was so much formaldehyde in the processing liquid that it was basically toxic. So in Brazil, there were multiple reports of hairdressers, becoming very ill and even dying from being exposed to high levels of formaldehyde. In the US, in one report, the FDA reported 47 complaints, and they included respiratory complaint, blisters, hair loss, nosebleeds, headaches, vomiting, and hospitalization. So now these keratin treatments are highly regulated by the FDA with the goal of making sure that there are not abnormal levels or high levels of formaldehyde in the products. So even though a lot of products will say formaldehyde free, there have been some people, consumer groups, who have tested things off the shelf and found that there is still formaldehyde in products that say they're formaldehyde free. Now, all products are allowed to have a certain level of formaldehyde, but obviously the formaldehyde is what's causing the straightening of the hair. So you do need sufficient levels of formaldehyde to get the desired outcome, which was straightening of the hair. So it's a tough issue, but I tell my patients, if it smells like formaldehyde, it has formaldehyde. And obviously formaldehyde has a very distinctive smell, even if it says formaldehyde free on the bottle. Now, hot combing, when I was a resident over 20 years ago, when we had very little research on hair loss in African American women, hot combing was thought to be a common cause of alopecia. And when I was a resident, there was a type of alopecia called hot comb alopecia. So hot combing was developed by Madam C.J. Walker. There was a phenomenal Netflix special on her, so you can watch that series if you haven't seen it yet. But in 1905, she developed a system where she popularized a hot steel comb, used it with her system to straighten African American hair. And using this system and by marketing this system, she became the first woman millionaire of any race on record in the United States. And she became, very prominent in the community and was very philanthropic. And so you should read about her or watch the Netflix series because it's absolutely fascinating. And what hot combing is, or sometimes people will say pressing, is when oil is applied to the hair and then the comb is heated up to over 300 degrees Fahrenheit and it's combed through the hair. And this temporarily breaks the disulfide bonds to straighten the hair. So when the hair is wet again, it basically reverts back to its naturally curly state. So it's not common in people who live in very humid climates like Miami, which is where I am, because it doesn't stay for very long in humidity. But in the past, it was implicated as a cause of scarring alopecia because at that time, researchers thought that the hot oil dripped onto the crown of the scalp and that hot oil was burning the scalp. And they thought that that's what was causing the alopecia, what we now call CCCA. Now we know that hot combing, it's never been associated in any study with CCCA or scarring alopecia. The newer version of hot combing is the silk press. So this is what most women do now. And basically it's because these flat irons have become very popular. And so this is just an easier way to do it. But you can see that the stylist is combing the hair and then using this flat iron to straighten the hair as she goes down. So in this method is not really associated with any particular type of hair loss, but it can cause breakage because we do know that heat damage causes your hair to become more fragile. So people who use silk presses regularly will have much more fragile hair than people who just keep their hair in their natural state. So this leads us into central centrifugal scarring alopecia, also known as central centrifugal cicatricial alopecia, or CCCA. And this is a progressive scarring alopecia on the vertex of the scalp. We didn't really know the cause, but I'm going to present some new research that suggests that it might be hereditary. So the prevalence in one series was 2.7% in South Africa, 5.7% in a North American series. And although in the original description of CCCA, there was no inflammation, in our current practice, patients often say that this hair loss is preceded by tenderness, burning, stinging, papules, or pustules. Sometimes my patients will say it feels like fire ant bites on their crown. So that you can have a lot of sensitivity, but there definitely are patients who have absolutely no symptoms. They just see this progressive thinning on the crown of the scalp. So what's new in CCCA? Well, this is a nice study that was published and it looked at 14 index African families in South Africa. And there were 31 immediate family members participated in this initial screening, and there were mainly women, but there were some men, so I think that's interesting. And the average age was 50 years old, and the average age of onset was around 41. And that is what I see in my practice. Women in their late 30s, early 40s present with this progressive thinning on the crown of their scalp. They did biopsy these patients, and all of them had histologic features of CCCA. And in their analysis, they found that it suggested an autosomal dominant mode of inheritance. So this is probably an autosomal dominant disorder. And the big take home here is that it's not caused by any particular hairstyle. I think that women who are predisposed to CCCA develop CCCA, even if they wear an afro. It is something that I've seen in patients with natural hair who don't process their hair, don't straighten their hair, don't use braids or extensions, any of that. And you can still develop CCCA. And of course, in the study, there were some men, and men can develop CCCA, and they generally are not straightening or processing their hair. So I do tell my patients that it does tend to run in families, and most patients will say, my sister has this, my aunt has this, my mom has this. So keep that in mind. I do think hair grooming practices can exacerbate it, and this is what this study found. So there is a way to measure the hair loss, and that's the central hair loss grading score. And when you have a higher central hair loss grading score of greater than 2, in this study, they found that those patients were more likely to have done frequent braiding or weaving. So 48% of patients who had a higher grade of hair loss had done braiding or weaving, and 29% gave a history of braiding or weaving on chemically processed hair or permed straightened hair. So in patients who had a lower central hair loss grading score of 0 or 1, they tended to have natural virgin hair, had never used any chemicals or traction on their hair, and had maintained short hairstyles, AKA the afro. So 35% of those patients were basically natural, who had the milder level of hair loss. And interestingly, these fell into 2 groups, either the very young, so less than 15 years old, or the very old, who were over 75 years old. And basically, it's because when young girls under 15 generally have not done multiple types of hairstyles, generally their hair is pretty, maybe ponytails, and that's about it. And older women had escaped all of the hairstyles that are very, very popular right now. So, the glue, the extensions, the braids, the all of those things that I've been talking about today were not as popular, let's say 40 or 50 years ago. And so they also escaped having more severe hair loss. And of course, the men who had kept their hair naturally short. So, so we do think that although that this is hereditary and appears to run in families, hair grooming habits can exacerbate it. So in this study, 35% of patients presented with thinning and breakage on the vertex as a main symptom. So they just presented with thinning and breakage. 29% were asymptomatic, and 35% had either painful papules, pustules, tender scalp, dandruff, or pruritus. And I do definitely see this in my practice. I'd say a third of my patients are asymptomatic. They just say, oh, I noticed some thinning. A third do have symptoms. And then I do see people who present with breakage. So what's the key take home here? If you see a patient who comes in with breakage on the crown of the scalp, that's their only symptom. You don't see hair loss, you don't see thinning, you just see breakage. If you see breakage on the crown of the scalp, think about early CCCA. And that's a great thing because you can intervene early and you can start treatment early and you can prevent this progressive hair loss. So the genetics studies, there's another study with 16 subjects with CCCA in South Africa, and they found mutations in the FAAD3 gene, which encodes a protein that's essential for proper hair shaft formation. And they saw reduced gene expression, they saw abnormal intracellular localization of the protein and decreased enzymatic activity. So this gene may be important in patients with CCCA. So when you look at all the studies, you look at things that have possible associations and no associations. So possible associations, when you look at these studies, they're kind of big survey type studies looking at people with CCCA. And the possible associations are traction, people report a history of damage, cornrows, braids and extensions, a family history, as I mentioned, a history of tinea capitis, which I think is interesting, use of hair dyes, and type 2 diabetes. Type 2 diabetes is interesting because some people think that this inflammatory, our current lifestyle is increasing our risk of lifestyle influence diseases. And those are things like hypertension, diabetes, and heart disease. And some people think this explosion in CCCA could also be due to this change in lifestyle where we kind of, don't eat lots of fruits and vegetables and we eat a lot of processed foods. And some people think of it almost as a metabolic syndrome of the scalp. Some people do. So that can increase the risk. Obviously, there's a genetic predisposition, but lifestyle may play a role. There's no association, interesting, with hot combs, reaction to a hair care product, male pattern hair loss in fathers, seborrheic dermatitis, and bacterial infection. So what about relaxers? So most authors do suggest stopping relaxers. There's some studies, the studies on relaxers are, I would say 50-50. Some show an association with relaxers and some don't show any association with relaxers. So I don't think we've teased that out, but obviously if you have an inflammatory condition on the crown of your scalp, applying a chemical probably won't help. It probably won't help. But if a patient doesn't want to stop relaxers for whatever reason, they can apply a base of the scalp, which is a thick petrolatum ointment prior to relaxers, and decrease the frequency of relaxers or touch-ups. But most people do recommend stopping relaxers, and now patients are very, very happy to stop relaxers. Years ago, it was much harder to convince a patient to stop relaxers, but now it's pretty straightforward. And actually, most patients stop relaxers before they come in to see me because although it's not a clear cause, they intuitively know that applying a chemical doesn't help, especially if you have burning and stinging and symptoms. So how do we treat CCCA? We treat it with intralesional triamcinolone, 4 to 5 milligrams per cc. I do it around every 6 to 8 weeks. 4 weeks at intervals if the patient is extremely symptomatic, itching, burning, and sensitivity, but otherwise every 6 weeks. I do that for a series of 3 to 5 treatments or until asymptomatic. But I tell the patients, if you become symptomatic, please come back. We can start this again because my goal is to prevent all inflammation. Now, we also can use clobetasol or any class 1 steroid topically, halobetazol. So all of the class 1s are excellent. If the patient has stable disease, completely stable, no inflammation, sometimes I add in some minoxidil. That can help with the coverage because it can cause some fine vellus hairs to grow. It's not going to cause thick, coarse, long hairs to grow, but maybe give you a little bit of coverage. If the patient is extremely inflamed, so itching, burning, sensitivity, papules, and pustules, we do oral antibiotics. Usually I use doxycycline, 100 to 200 milligrams daily, but rifampin and clindamycin combined have been reported. And then again, if they're stable, you can consider PRP, which is platelet-rich plasma. And I'm going to present some information on that. Metformin, 10% topical solution, has also been presented as a treatment or reported. And then there's less evidence for hair vitamins to treat hair loss, but you could consider biotin, which may strengthen existing hair. So when I see a patient with CCCA, I explain to them everything I've told you in this lecture. So I say this is likely hereditary. Hairstyles can exacerbate it, but don't necessarily cause it. We're going to treat you today, and my first goal is no further hair loss. So I think if you see me 10 years, we see each other for 10 years, and your hair looks like it does today, 10 years from now, that is a treatment success. Why is that a treatment success? It's a success because the natural progression of CCCA is to grow. It starts small, and that circle expands. That's why it's called centrifugal. So if your hair is stable and we completely halt this process, that is my first goal. And that's why it's very important to catch those patients early who have very mild breakage or thinning on the crown of the scalp, because you can basically prevent the hair loss. My second goal is to possibly grow new hair, and they can expect a 10 to 30% regrowth of hair. So you can see here, this is one of my patients who was treated with clobetasol foam and intralesionals, 4 milligrams per cc. And you see, I'd say this is around a 30% regrowth of her scalp. A lot of patients, a lot of physicians will tell me, oh, it's completely scarred. There's no chance of the hair growing back. But I will tell you, these patients will surprise you. What looks like completely scarred hair, scarring alopecia, can have a propensity for growth. So I don't want you to say there's absolutely no chance. I give them very realistic expectations. I say, my goal is that you have no further hair loss, and there's a chance that some of it can grow back, some. And that's with very compliant patient who comes in for injections and uses topical steroids at home. Now, I mentioned metformin 10%. So this is a case report that was reported just a couple of years ago. And it was a 69-year-old Black woman with biopsy confirmed stage 4 CCCA. And she reported onset of a hair loss in her late 50s. And she had previously been treated with minoxidil 5% foam twice daily, 8 cycles of intralesional Kenalog, topical clobetasol, and a hair vitamin called Viviscal. She didn't see any improvement. And after 5 years of the standard therapy, she stopped the intralesional, she stopped the topical minoxidil, and started on the 10% metformin cream. And we see beautiful regrowth here. I'd say this is almost 50%, maybe more than 50% regrowth of her hair. It was started at 3 times a week and increased to once daily. And this is her at baseline and at 6 months. So I think those are great results. I do use this in my practice. I can't say, and this is a relatively new treatment, so I haven't seen a lot of patients and follow up, but I do think that it could play a role for patients, especially for patients who may have failed conventional therapy. PRP is another treatment that has been reported. I absolutely do this in my practice. And it is platelet-rich plasma. If you're not familiar with that, that is when we take the blood from the patient, we spin down their own blood, the plasma is on the top, the red blood cells are on the bottom. We take that plasma, which is full of growth factors, and inject it into the scalp. The treatment is actually painful. It does hurt because you are injecting, it's not like intralesional Kenalog, which is basically a liquid. The plasma is thicker, so it is a little bit more painful than typical scalp injections. Another treatment you can do is you can do microneedling to the scalp and then apply or rub the PRP, basically the serum into the scalp. And there are 2 methods. I don't tend to do the microneedling because people of African descent, their hair can be a little more fragile. So I don't do the microneedling as much because I do worry a little bit about breakage, but I have many colleagues who have excellent results. So there are 2 ways of doing PRP. One is injected, the other is with microneedling. Both have been reported to be efficacious. So I do this in my practice, and I'd say I see a 90% response rate in my patients. I have 1 or 2 who were non-responders, but these patients love this treatment and keep coming back. And of course, this is an out-of-pocket treatment. It's not covered by insurance. The price ranges from $300 to $400 per treatment, and depending on where you live. If you live in more expensive cities, it could be $600 or $800 a treatment. So it really just depends, but it's a great treatment option. Hair transplants is another option that I do refer my patients for. I don't do hair transplants, but I do refer to hair transplant surgeons in our area. This is a case report reported by Dr. Callender, and it showed 2 African-American women with 5 to 6 years of progressive hair loss on the crown of the scalp. And she did biopsies before to prove that, first of all, that they had CCCA and it was stable, it wasn't active. And then both patients underwent hair transplantation with using round grafts. So normal hair transplants are micrografts or 1, 2, or 3 hairs, but this used round grafts because it's on the crown of the scalp, it's not the frontal hairline. So you don't have to worry as much about the cosmesis of a round graft, which is basically like a tiny punch biopsy. So there was no postoperative scarring in the recipient or donor sites on the scalp, and it was well tolerated. And these are some of the results. So you can see that even though, you know, this is not a full head of hair, she has some coverage here. And this is 2 years later. So these grafts really did stay. And I think for this patient, she's happy because you don't see this round, shiny bald spot, which is much harder to cover than when you have some hair there. When she pulls her hair to cover this, you get this illusion that the hair is full. Now let's move on to traction alopecia. I'm just getting a text here, so I want to make sure that it's not from the meeting. Okay, good. I'm doing okay on time. I just want to make sure we were okay on time. So traction alopecia is something I see all the time in my practice. This is your classic case of traction alopecia where you see these thin hairs on the frontal hairline. This is early traction alopecia before all of the hair is lost, but we see thinning of the hairline. Sometimes our patients will say, I am losing my edges or my edges are thinning, and that's traction alopecia. So this was a nice paper that was published in the Blue Journal, and it talked about different hairstyles that increase the frequency of traction alopecia. And I absolutely tell my patients this information. You can print out these handouts and hand them to them also. I usually say it verbally, but the things that are high risk for traction alopecia is frequent use of tight buns and high ponytails. So a ponytail that's high is pulling the hair up and away from the scalp, away from the forehead, and that is much more likely to cause traction than a low ponytail where the hair is being pulled down. Using braids or extensions or weaves on chemically straightened hair. So we know in studies that tight braids or extensions increase the risk of traction alopecia, but exponentially so when they're done on chemically straightened hair. So it increases the risk by 5 times. So if a patient chooses to use weaves, braids, or extensions, you want to do that on chemically not processed hair, not chemically straightened hair. So you want to avoid someone has their, I think we need to mute.
The French vanilla swirl latte, large, hot.
Let's see. Okay, and there we are.
Let me do,
I hope you all can hear me.
The double.
One moment, okay. Let's see if we can get them to mute.
And and a glaze.
Let's see. All right, now I think you can all hear me, right? I just want to make sure. Let me take a look at the chat.
Yes, we hear you.
Okay, yes, great. Okay, so let's jump back in. So as I mentioned, if your patient wants to do weaves or braids, they need to do it on natural, unprocessed hair. Again, if you do tight braids, cornrows, and very long dreadlocks, so heavy, heavy, heavy locks can cause traction alopecia. And as I mentioned, any hairstyle that causes pain, stinging, crusting, tenting, or pimples. So moderate risks, looser braids, weaves and braids apply to natural hair, hair extensions apply to natural hair, wigs worn with a cotton or nylon wig cap, and permanent waving. And then low risk, as I mentioned, low ponytails. That's a big take home, a very simple intervention. I tell my patients who love high ponytails or want their hair out of their face because they're exercising, do a low ponytail. Wigs worn with a satin cap, and of course, natural unprocessed hair is the lowest risk of traction alopecia. So I won't go into all of this in detail, but these are nice little tips you can tell your patients. So you can print this handout and give it to your patients. So, and the reference is down here at the bottom. You can print that out. So you can leave braided hair, don't leave braided hairstyles in for longer than 2 to 3 months. Opt for larger diameter versus tiny little micro braids. That's because micro braids, the little tuft of hair at the base of the scalp is so tiny that it really, the weight of the hair can pull out those 4, 5, or 6 hairs that kind of holding this long braid. So although micro braids, people love them, they are not great for traction. They really, that's probably the most common thing. My patient will say, I got some micro braids and my whole frontal hairline was gone when they took them out. hair extensions should be used for short periods of time. Remove weaves or extensions every 3 to 4 weeks. Another simple tip that I tell my patients is alter the pattern of the cornrowing. So if the stylist does cornrows in one pattern, the next time she goes, try to do a different pattern. So the hair isn't constantly being pulled in the same direction over time. Now we'll move on to frontal fibrosing alopecia. And frontal fibrosing alopecia is increasing in prevalence in my practice. This is hair loss along the frontal hairline. It can also be associated with hair loss in the eyebrows and the underarms. And it's in the differential of traction alopecia. I think that for years we might have been misdiagnosing this as traction alopecia until we took a closer look. So what's taking a closer look? You want to look for perifollicular erythema. So you can see here, you can't see it as much because it's a little bit far away, but you will see hyperkeratosis around each hair follicle. So the hair follicle almost is like has a little bit of inflammation around each individual hair follicle. That's a very classic finding on the frontal hairline. Obviously, you see scarring. You can see a shiny looking hair. The hairline's going back, and right before the hairline goes back, you see this shiny area. That's where her hairline used to be. The other thing, if you look at her forehead, you see these little tiny kind of pinpoint papules on her forehead. This is likely this disease process affecting the vellus hairs on her face. So we do see these tiny follicular pinpoint papules on the forehead and the cheeks. So this was actually first described in 1994, and it was first described as a hair loss disorder seen in post-menopausal Caucasian women. But in my practice, I see it most frequently in premenopausal African-American women. And there was a case series presented showing that when African-American women develop frontal fibrosing alopecia, most of them are premenopausal. You can see here between 39 to 75% present premenopausal, whereas in Caucasian women, the minority of women present when they're premenopausal. So this condition was a hot topic because there was this possible association with face moisturizers and sunscreens. This topic is still somewhat controversial. The original paper that was published was then refuted, and there may have been issues with the statistical analysis. So I think the verdict is still out on this. But some things that have been possibly associated are sunscreen, UV filters, and hair care products. But there is insufficient evidence to establish a direct causal relationship, so the search still continues. And this is just a close-up of this to really point out these fine little papules. This is very characteristic on the frontal hairline, so something you can look out for. And if you notice, her eyebrows are either tattooed in or penciled in. That's another clue, clinical clue for your patients. Again, this demonstrates us. This is traction alopecia. You see the fine rim of short hairs. These are the hairs that were too short to be pulled into the tight ponytail. And this patient was funny because I said to her, oh, you know, you look like you have a little traction alopecia. She said, no, it's hereditary. Everyone in my family has that. But it's probably because everyone in her family wears these tight ponytails. So it's definitely not hereditary. This is 100% due to tight ponytails, which you can see her hair is pulled back very tight. This patient looks a little different. You really don't see that little, the fine rims on the frontal hairline. Sometimes you see these stray hairs that escape the inflammatory process, but it's not this fine rim that you see on this picture. And you also notice that this patient, if you look closely, has lots of eyebrow hair. This patient has no eyebrow hair and her eyebrows are tattooed in. So that's another clinical clue. So how do I treat these patients? I personally do intralesional triamcinolone, 4 to 5 milligrams per cc. Again, at 6-week intervals. You do need to use caution because you are injecting right next to the face. So I do try to keep it right at the hairline, make sure I'm on the scalp and not really on facial skin when I'm injecting. I'll do topical tacrolimus for this reason, because we don't really want to use high potency steroids on the forehead. In one case series, 97% of patients treated with intralesional corticosteroids had hairline stabilization and a reduction in their symptoms. And 31% of the patients in this case series of 62 subjects were able to stop treatment and remain in remission from 6 months to 6 years. So I find intralesionals to stabilize. They sometimes regrow, but they definitely will stabilize the frontal fibrosing alopecia. There was another paper that reviewed the literature, 270 papers, mainly case reports and retrospective studies, and they found that both intralesional steroids and 5-alpha reductase inhibitors were effective at the same rate, 88%. Now, there was some data afterwards, again, refuting this study, but it's something that many people in my university use, our 5-alpha reductase inhibitors, also to treat frontal fibrosing alopecia. One other take home, this condition is associated with lichen planus pigmentosus. This is one of the most difficult pigmentary disorders that I treat in my practice. And 14% of patients have autoimmune connective disease. So it's important to check an ANA in these patients because you might capture some autoimmune disease or even hypothyroidism. So I check an ANA and screening thyroid labs in these patients. So this is just to show you this patient who has the frontal fibrosing alopecia. This is very early, but you see that deep slate gray pigment that we see with lichen planus pigmentosus. This is a patient that was followed by Dr. Tosti at University of Miami, who was being treated for her frontal fibrosing alopecia. She was stable on topical tacrolimus that had been stable for 9 years. So she was really doing well. Again, look at that perifollicular prominence that we see there. And then she came into me many years later with a new onset of dermal pigment on the neck, and that was present for 4 months. This is a very difficult condition to treat, and the topic of another talk, but something to look out for in your frontal fibrosing patients. So in conclusion, with CCCA, pretty standard treatment is either topical or injected steroids, but we do have lots of new interesting treatments on the horizon. So I'm definitely doing PRP, referring people who are stable and are very interested in hair transplants. That's something you could consider. You can consider topical metformin that has also been reported. For traction, you have now a nice list of ideas or actually instructions that you can give your patients to help them avoid traction. So hairstyles that avoid traction. With traction prevention is key. We avoid tight hairstyles, use that handout. Occasionally I'll do topical minoxidil, but traction alopecia is definitely a challenge. And by the way, hair transplantation is done for traction alopecia. And I've seen it used successfully. And the other thing I've seen used more recently, and I'd say in the last 6 months, is where plastic surgeons actually change the hairline. So they'll cut out where the traction alopecia scalp was, that affected scalp, and actually bring the hairline down. They call that hairline lowering surgery. It's a very invasive surgery, but it's gaining popularity. I'm very active on social media, and it's very, very popular right now on social media for people who have traction. That's something that I think is on the horizon. That's brand new. We'll see how that works long term. My biggest concern is scarring, because obviously our patients of African descent are at higher risk of scarring. Frontal fibrosing alopecia, this is not uncommon in Black women. We used to think it was, but it really isn't. It's common in premenopausal women. Look for lichen planus pigmentosus, check the ANA, and you can treat with intralesionals, 5-alpha reductase inhibitors, topical steroids, and topical calcineurin inhibitors. And most importantly, big take home, advise your patients against glue due to the risk of scarring alopecia and anaphylaxis. So thank you so much. I think I do have time for questions. I'm going to stop sharing my screen here and see what kind of questions we have. Okay, so.
Yes, and we have a chat monitor that can even also ask those questions for you.
Okay, great. So I will look in the chat because I do see quite a few questions here. So I'll start at the top. Okay, so it says, do you use immunosuppression modulation such as hydroxychloroquine for CCCA? I personally don't use a lot of hydroxychloroquine, but I have many faculty members at my university who do use hydroxychloroquine. I think it's great for hair stabilization. I tend to use a lot of intralesional steroids. I like them because I can pretty much guarantee they stop symptoms. So when people complain about itching, burning, and sensitivity, I can pretty much guarantee that will improve with intralesional steroids. So I don't use them as much. I don't use hydroxychloroquine as much, but definitely a common treatment that is utilized by other colleagues of mine at the university. Okay, so the next question says, if a CCCA patient is no longer experiencing inflammation and their inflammation is under control, is it okay for the patient to seek hair transplantation option, or is that treatment option ever recommended? I do have sent patients for hair transplants. The surgeons are very careful. So those surgeons will do biopsies, they'll optimize the hair growth with other methods. They don't jump into surgery. So the surgeons who do a lot of hair transplants in Black women with a history of CCCA, because there is a point for many of these women where this disease basically, quote unquote, burns itself out. So there's no more active inflammation and the process is over. And I do have surgeons in my community who will do hair transplants, but they do spend some time. It's not like the first day they go in for their visit, they get a hair transplant a week later. I think the surgeons really want to establish that there really is no inflammation in the scalp, and this is a burnt out disease process. Once they have established that, they have reported good results. Okay, wondering about low dose oral minoxidil rather than topical. That's a great question. So I have used low dose oral minoxidil in patients with non-scarring alopecias and occasionally scarring alopecias. It is an effective treatment. There's only 2 problems with it. And that's usually the 5 milligram pill, and people take a quarter of it, so a tiny, tiny dose of minoxidil. The problem is that, first of all, patients will sometimes complain of excessive hair all over their body. And that is actually how topical minoxidil was discovered. So I used to work with a doctor, his name was Dr. Khan, and Ginter Khan, and he was a dermatologist on faculty at University of Colorado when he was a young faculty member, and they were doing the clinical trials for minoxidil as a blood pressure medication. They called it a derm consult because the women and men, but women primarily, were complaining of excess hair growth all over their body. So Dr. Khan and his resident crushed up the pills, put it in a 2% alcohol solution, and applied it to their forearm every day underneath a Band-Aid. And they found that this 2% alcohol solution caused hair growth. It actually caused a little contact dermatitis in Dr. Khan, so he stopped because some of our patients do get irritated by minoxidil. But his resident, after several months, had a thick patch of hair underneath that Band-Aid. It's a very interesting story. You can read about it online, but basically the pharmaceutical company filed the patent after he reported it to them and did not put him as an inventor, and developed the drug, over years. And meanwhile, he was fighting along, and in the end, they settled for an undisclosed amount. But that was actually discovered by a dermatologist that I used to work with here in Miami. So low dose minoxidil absolutely will grow hair, but the side effect is hair all over the body. And because I practice in Miami, and this is a very, a place where people, their arms and legs are exposed, and this is a sunny climate, a lot of patients don't like that side effect. Now, the next thing says, Nicole has 2 questions. Oh, you did ask them. It says, how many rounds of intralesional Kenalog do you typically do for CCCA? So I do treatments every 6 to 8 weeks for a series of 3 to 5 treatments, or until asymptomatic. And if they are asymptomatic, but they regain symptoms. So 6 months later, they start itching and burning, I tell them to come right back in. So I always treat symptoms. The next question is, how much does the 10% metformin cream typically cost? It's $60. I use a compounding pharmacy that makes a solution, not a cream. And it comes either in like a dropper tip or a sponge pad tip. And patients have used it with really no problems, and it's relatively affordable at $60. Other than the systemic concerns for formaldehyde and Brazilian blowouts, should we be concerned about hair breakage and scalp scarring? Anything that breaks those disulfide bonds is going to weaken the hair. Now, I don't think a study has been done to look at the cysteine levels in keratin-treated hair, but I do think I can say from my personal experience, my patients will say that they have some breakage from keratin. That being said, a lot of them still really love this process because it makes their hair so much more manageable. So they're willing to trade the little bit of breakage for the improved manageability. So, you know, as I mentioned, I'm in Miami, a very humid climate. And so frizziness is a big problem here, and keratin treatments really reduce frizz. So our patients here in Miami do like this treatment. But there is a concern. Most patients do report some breakage, but they're willing to do that trade-off if they love keratin treatments. Okay. Have studies explored the scalp microbiome? Oh, I love this question from CCCA, and even the mast cell mechanism. So the microbiome is something that I have a real interest in. I think that we underestimate the role of the microbiome. No, and to my knowledge, studies have not looked at this, but this would be a great study to see the differences. Now, I always do emphasize that CCCA is likely a genetic condition that your patients have a predisposition to, and then other factors can influence it. I really make sure to tell the patients it's not their fault. Don't say you're doing this to your hair, or it's because you did this or because you did that. I really do take the blame off of the patient because it isn't their fault. It most likely is a genetic predisposition, and hairstyling techniques can exacerbate it. So no one has studied that. And let's see, and the mast cell, that has been studied a little bit, but I'm not as familiar with the outcome of the studies. Okay, so if only symptom is hair breakage on the crown and concerned about early CCA, is biopsy helpful, or do you just start empiric treatment? That's such a great question, because as we all know, scalp biopsies are never fun, but they are helpful. So I do try to biopsy in my patients who consent. A lot of patients don't consent to biopsy, by the way, because they want to treat first. But if they consent, I do. It helps you know if there's a lot of active inflammation. But for a lot of my patients, CCCA is a clinical diagnosis. Now, you can miss things. I will tell you that you can miss things. If you see a lot of scale, that can be, you know, tinea capitis. I've definitely had a patient who presented with what looked like classic CCCA, but she had scale. She did have a slightly more scaly scalp, and when I biopsied it, it was tinea capitis. So try to biopsy if the patient consents. It's helpful to see the level of inflammation, but for a lot of patients, it can be a clinical diagnosis. It says CCCA is most commonly found in African-American women. What tools are being used to recruit and diversify clinical trials and increase NIH research funding in order to better understand this disease? How can medical students assist? I love this. So there is the Skin of Color Society, and the Skin of Color Society is focused on education, research, and mentorship in the area of skin of color. So there are opportunities for researchers, a large research grant that's given every year, and some smaller research grants, opportunities to do research. And we have some phenomenal researchers in the US who do great research, Amy McMichaels, lots of doctors who do research on CCCA. So I think that if you are interested in that, look at the Skin of Color Society, look for mentorship opportunities there and people who specialize in hair disorders and specifically research in hair disorders. And that's a good place to start. Topical metformin, to go along with Courtney's question on price. How often do you have patients use it? And can most compounding pharmacies make it, or is there a specific pharmacy? So I use a pharmacy called Hairstem, which is like, it's based off of, I don't even know where it's located. You find it online. But I think most pharmacies could make it. I have the patients use it once a day. And I think that answers the question. Is scarring alopecia from hair glue primarily due to inflammatory contact reaction or tension of the scalp and the hair shafts? Can hair glue cause scarring alopecia in the absence of contact reaction? You know, that's a good question because I don't think it's been studied, but my gut reaction is that most of the people who have reactions to hair glue, it's an inflammatory allergic contact dermatitis. They report burning, stinging, and irritation. The second possibility, though, and I will say this, is they'll say they didn't have the right solvent, because to remove the glue, you have to dissolve it. It's glue. And so they'll say, I didn't have the right solvent, and so I kind of pulled it out. So there is a mechanical component to hair loss from hair glue when the glue is not dissolved properly, and the patient kind of gets desperate and basically kind of starts to tug more than normal. So it is a lot of damage. It is a lot of mechanical damage too, in addition to the allergic contact dermatitis. But those very brisk reactions that you saw in those images, that is truly an allergic contact dermatitis, and maybe even a component of irritant contact dermatitis. I love the latte, sounds delicious. So let me see if I see more. Can men with thinning hair use metformin for hair growth? Can it be purchased over the counter, or do you need an RX? You do need a prescription. I'm not familiar with research on men using it, so that's a great study for medical students who are out there listening. And but you do need a prescription. As I mentioned, it's around $60 at the pharmacy I use. Some of my African-American patients don't like the vehicle of minoxidil. That's a good point. Oh, I'm going over, I'm so sorry. So this might have to be our last question. So the vehicle, do you have suggestions? Yes, that's a great question. So there is an over-the-counter 2% called Minival. I'm not sure how to spell it, but I think it's Minival, and it is a 2% minoxidil oil. And so patients do love that, and that one does also work. I don't know if it's easy to find. I've never looked for it, but a lot of my patients buy it at their beauty supply store. So I know I'm a little bit over. Should I wrap it up right now?
I think we're good. Any final thoughts?
I just wanted to thank you for inviting me. This is such a fun talk to give, and I hope everybody learned something new. And I'm looking forward to a great symposium for the rest of the day.
Excellent. Virtual applause. Thank you so much. We always enjoy your talks, and they're so enlightening, easy to understand. And I think every one of us can glean some new things out of this. So I know I did. So thank you so much.
Thank you.